So, welcome to the final episode of Diversity, Equity, and Inclusion. And it's a great honor for this final episode. I would like to thank Radcliffe Cardiology for letting us host these episodes with the platform. And it's a great honor to have Professor Roxana Mehran with us, who is the Vice President of ACC and founder of Women as One. Roxana, just a bio like your CV is endless. You are a pioneer in cardiology. You inspire a lot of women. And first of all, you're the founder of Women as One in 2019. And within these years, there has been a huge, massive progress. Like you just closed the Climb program. The deadline was like a few days ago. And we've seen a massive response with applications. There is the Rise that is coming one day before ESC. And me and Mirvat, we have been there and we will be there. So we encourage all colleagues to register and attend this. It's a very inspiring opportunity for everybody who is listening to this podcast. And also to mention that you have been one of the founders for CRF, Cardiovascular Research Foundation. You've been a pioneer in women's health, receiving multiple awards such as the ESC Silver Award, the Andreas Grutznik Lecture, and ACC and multiple AHA awards. So it's a great honor to have you. And I want to start on behalf of myself and Dr. Mirvat Alasnag that we are running this podcast. The first question is your dual role as founder of Women as One and upcoming president for ACC. What are your priorities as the founder of Women as One and also as vice president for ACC?
First of all, let me thank both you and Mirvat, if it's okay. I mean, you're both such pioneers yourselves, and so incredible to have this kind of a program at a time that we are sort of questioning the DE&I situation with around the world. And that kind of bravery and bringing up the very, very important issues of inclusivity for all people is incredibly important. And also the fact that we are all thinking about the same thing, promoting and improving heart health in all humans, no matter where they come from, no matter what sex or gender. We want to reduce the global burden of cardiovascular disease, and we can't do it without all of us united, working together, singularly and collaboratively. And I think that is really sort of the bottom line of how I see ACC working on a global level, reaching out to pretty much all places of the world to try to bring people together. Our membership is over 64,000 members strong in the health field specific to cardiovascular disease. And I think it's the singular organization that cares deeply about the workforce and will do a lot of work to enhance that and work together hand in hand with our sister organizations, I would call it, the European Society of Cardiology, as well as the American Heart Association, with the very, very same types of vision and mission to really work together hand in hand and reduce the global burden of disease. So having said that, we can't do this without having our workforce also be diverse, also very inclusive, and importantly, focusing on women's health. And we can't do it without having some women in the field of cardiovascular disease. It's one of the most rewarding fields, yet it's male dominated, difficult for women to thrive and get to very high levels of professorship, leadership. And we all have stories. I think we don't really want to air those stories out too much, but the fact of the matter is that the resilience, the grit of women is unparalleled, and that we're working very, very hard together to be sure that there would be one organization that does nothing but to promote these talented women in the trenches who are working and maybe perhaps not being recognized, not being lifted, not being able to climb or escalate to the next levels. And we want them all to rise. And so all of that is part of what Women as One is doing. And that was sort of a thought that if I'm living on this earth for the small amount of time that we're all here, that we must be sure that there is something good and we pay it back. I've been given great opportunities, as you all have, but I've also had a lot of setbacks. And despite that, I've been able to kind of strive through it. And I felt that it was very, very important that we gave a platform for women, and for women to recognize that cardiology is a wonderful, wonderful opportunity to not only work together across the globe because it's such an important problem, but also to be able to join and be sure that women had a home, that they could absolutely be um, trusting trusting an organization that really deeply cares about them and is doing nothing but to elevate them. And so that's the two things, and they're kind of separate but also similar. And I feel very humbled and extremely proud to be able to represent both of these organizations, but also my own institution that's also working very, very hard towards the same goals. And importantly, thinking that no one is greater than another. We all have to work together and join hands. And this kind of a connection through this important podcast, webcast, whatever you want to call it, is so very important and so fundamentally essential at this time. So thank you for doing that.
Roxana, you've been a role model for many of us and for generations. So, for our younger colleagues who are seeking to find their niche and wanting to become impactful, what advice would you give them, and how do we define impact?
Yeah, so really good question. My advice to my own younger self is to make sure that you balance your life first and foremost. I think one of the things that happens with women, we feel so um, sort of, we have to be there at all times to even receive the crumbs off of the table. And I think for that reason, we end up sacrificing much of our own personal lives. And I think that when I look back, I would say you need to work hard, but you need to balance your life. You need to believe in yourself, and you need to just make sure that everything that you do is deep, not just surface like, and absolutely with depth and breadth, with commitment. And even if it's a small task, do it to the best of your capability, but be sure that you have a balance in your life. I think what happens with women now is that they are now coming into cardiovascular disease subspecialty. They're feeling like there is a hope for them. They work so hard, they don't balance their life. They are not able to have the friends, the family, and the time that they need. And then they end up not being really happy and then leaving after all of that work and losing both of those things. And we don't want that at all. And there is a really, really important piece of advice that I have for every woman is to really go out there. And when you have setbacks, don't give up. Just keep going, because there'll be, when doors close, windows open, and windows open, air still comes in, and breathe that air, and then absolutely use it and energize yourself for the next level of escalating and climbing and rising. And I think that is really sort of a big, big advice that I have. And impact is very important, but if you do good work and don't even worry about the impact, have the good feeling of answering questions that matter to patients and to physicians, to clinicians in the most best way, honest, and not be lured away with commercialism, self promotion, or anything like that. Work hard, answer the question, publish, be out there. Don't say no, don't accept things and then walk away from them. Take the opportunities, but choose well on the things that you can do. If you cannot be there, make sure you communicate why you cannot be there so they don't give up on you and not invite you again. Do those things to really, really promote yourself with your own self. not to others, but for yourself. Believe in yourself. And I think that all works. And then at the end, the impact comes through. When I think about all of the setbacks that I had, I often thought about what's next, what can I do next, and really dove in, worked really, really hard, never gave up. And when you do a concept that you have, like against all odds of, let's say, a question of can I drop aspirin, and thinking about that and taking a decade, it takes a decade of hard work, right? It took us a couple of years to get funding for that project, a couple more years to actually implement it and enroll patients and get them to the finish line with a lot of hard work, a lot of gray hair. And then 5 years later, everyone else followed with multitudes of similar evidence. And now we have a class 1 indication for the idea that I had a decade ago in 2015. And in 2025, there's a class 1 indication. And I think about not because of that, but because now that it's in the guidelines, we will save bleeding. We will make things better for our patients. And that's impact. It's also impact on a topic that nobody wanted to do, like contrast-induced acute kidney injury. Nobody wanted that. The boys didn't like that in my group. So I got that, the lemons of that pile, but I made lemonade with really understanding and bringing forth the issue of not injuring the kidney during your procedures. So it's just a couple of examples. And then the New England Journal asks me to write the review article on the topic because I dove deep. I put in a lot of time, a lot of efforts. So I would just say, think like that, not what's the quickest thing to get to my final place, but really think through and think about the patients every time you're doing something. Think about the patients you're impacting and the mark, the indelible mark that you will be making with your work. And that in and of itself is the most gratifying, amazing feeling. But make sure that you balance your life.
Thank you so much. Again, you are an inspiration, and many times when you speak, you tears are coming to my eyes because I think R3 we've listened to a lot of stories, and you say everything as from the heart as it is, and you're coming a lot of advice on how to grow. That I hear you, and my question to you, Roxana, is except from the personal part that we need to have resilience and patience, and of course it takes a lot of time and a lot of failures to reach to that point. How do you feel the role of organizations? Like we see, we are discussing a lot about female leaders, about like presidents, about editors, about editorial boards. Like we need more women, that they deserve to be there, of course. I don't say that there is no merit, but do you feel that organizations need to reward good people, or need to have in mind the 50-50 balance, or is not actually an organization's work to police this process? What is your opinion about this?
Yeah, I think, I think very, very importantly, it is important for everyone in the world to know that no woman wants to be chosen for a position if she's not qualified for it. Nobody wants that. Who wants to be in a place where you're absolutely uncomfortable in your skin, anxious that you are not good enough because you're not good enough for that position? Nobody wants that. Nobody wants that. I promise you that nobody would want that. That would be hell, a hell to live in. So meritocracy is incredibly important. But I would say that we have to, in order to find and bring women up, we have to have a different lens on, because of the unconscious bias that we all experience and we all have, and because of the previous past that has been completely led by our male colleagues, and the fact that I still, to this day, on a daily basis, have experienced some of those biases that we all feel in the way people talk. And they're not meaning it. It's just unconscious. It's not like they're bad people. They're just it's just the way the brain has been wired, and it takes very long time to do that. Organizations are helping, but this idea to put a number of 50-50 rule, I think it's unfair because it's difficult. There aren't that many women out there. So if you make it a 50-50 rule of women speakers and things like that, and women are saying no because they want to balance their life, as I just asked them to do, then you really are put in a bad place of having the wrong people on panels, on editorial boards, in leadership positions, in C-suites. But that doesn't mean that we shouldn't have a lens of putting on a lens with a different lens of looking for talent in women, because I think the lens is quite there for men. They self-promote, they know how to promote each other. Women don't have those networks. In fact, other women bring down women. Unfortunately, we've seen it, I've felt it, it's happened to me. I think we have to kind of have an open mind. We can't swing the pendulum to one side or the other. We need to come somewhere in the middle and oscillate back and forth, understanding that some days it goes in this way and another day it goes in the other way. But in the end, an equilibrium will be reached if women are given the opportunity. So those are the things that I think about. I don't think that you have to put a number on it, a percentage on it, but I also don't think that we should only have 8 chiefs of cardiology in the United States, because I am certain that there are more women who are qualified for that position. And what can we do to those positions to make them more friendly and attractive to women? Because I personally have given up. Wouldn't want to be a chief of cardiology if I'm always going to be looked at with multitudes of microscopes because I'm a woman in that position. And I certainly know that many times they choose women when things are falling apart. So if it goes even in the worst direction, then they can blame it on the woman. So these kinds of things need to go away. We need to all work hard and find merit in its essence and bring people in, not because we're trying to make some kind of a number, but actually because we really want the right expertise for the right job at the right time with the right person. And I think that is really what everyone should be looking for. But also, and importantly, we need to teach women how to network, how to get closer to one another, how to make sure that they have the expertise for the jobs that they're looking for, and not prematurely ask for jobs and super confident way. In a way, I've seen it actually. There are some women who are kind of talking over other people, thinking that their confidence will help them gain what they're looking for when they actually don't have the merit to speak about a certain topic. That makes them look bad and awful. So we need to be respectful and understand how we could, in this, especially in this current environment, to be sure that everyone who's looking, to be sure that they're merited for the places that they're going. Now, let me just say, this doesn't mean that all men are receiving their promotional and leadership positions because they deserve it. There are many who don't deserve it. They just walk in it with no problem whatsoever and pretend, and they kind of fake it till they make it. We've seen those. That exists in both men and women. But I think we need to kind of think about on both levels to be very, very fair and choose the right person for the right, with the right expertise for the right job. And it will really be a happier medium for everybody. And we will stop complaining. But our work is so not over, I tell you, because I feel it still every day. And there are still some of these last generation or 2 generations ago that still see us with it at a lesser level than we deserve to be seen. And so we need to push back on that. So our job is not over. I don't know if I answered the question, but it's sort of it's a difficult question to answer.
You answered it and put a wonderful perspective to merit, really, that is worth pausing and thinking about. I do want to shift gears, though, and congratulate you on the Lancet Commission on the cardiovascular health for women. And, you laid a blueprint on what we need to do moving forward in terms of research. And you put that to action yourself. So you did the SMART trial, for example, and you have 87% recruitment of women in that trial. So you're really leading by example. And can you tell us a little bit more about your ambition with research that's dedicated to women's cardiovascular health?
Well, thank you, Mirvat. I think it's one of the most crucial and important topics, because once again, we can't sort of use the same methodology for men and women in terms of inclusion of them in clinical trials. If we set boundaries that exclude women, we will have less women. If we have age limits, if we have comorbidity limits, women are always often older with more comorbidities, so they just get excluded from clinical trials. We can't be so dogmatic in the way we are approaching patients to come in when we're not thinking about the intangibles of what women are feeling when they're listening to a doctor who wants to bring them into a clinical trial, not understanding that 17 visits for over a 4-year period is a very difficult thing for women to do. For men, it's easy because their wives bring them there and they take care of everything else. But for women, it's a lot more difficult, especially if they're taking care of their children or their loved ones and holding down 2 jobs, or if they're single. There are all kinds of issues. We've never dug into those things. And also remembering that women often are not, when they come and they present, they're almost sicker and they're not really in a place that fit in our clinical trials. So we have to kind of reboot the entire system if we want to enroll women or, deprived individuals, whether they're of different races or of different education level. If we want to be all inclusive, we can't be exclusive in our clinical trial sort of methodology and how we're moving ahead. So we have to reboot the system. And we set that path and the blueprint in the Lancet Commission. And I think many are thinking about that. I mean, I'm on several clinical trials where we have a steering committee that does nothing but to think about how do we make this trial better for enrolling more women? What should we be doing? Where should we be going? What community of women do we go to spread the word and bring them in? And I think there are a lot of opportunities. And now with AI and technology, with the ability to kind of go out there in women's groups and women organizations and other communities, we're going to be able to bring in women. We also have to make sure that we know how to talk to culturally diverse individuals and make sure that we're not really showing up with a demanding thing that this is what it is and you want to in or you don't want to in, and those kinds of things. There's got to be a conversation, a sense of trust and understanding, and how we speak to our patients, that when they come into a trial, they're really very well cared for because the group wants them to do well, whichever arm they end up in. And I think those are the kinds of things that patients don't know about. They think you're testing something on them and that, well, what it could be dangerous. And what if I miss work? And what if I'm not there for my children? And these are the kinds of things we have to be very, very cognizant about and think through. Maybe we make home visits, maybe we do other things. And we never did that. And so now we are really, really changing the way we're going to be doing clinical trials. I'm actually very, very excited about incorporating AI, pragmatic designs, large numbers of patients, a very, very quick enrollment and quick answers to our questions. And I think that's the future, and much more inclusive and all-comers studies through a platform, actually, where investigators are signed up because they're interested in enrolling diverse patients, and you just get in and you bring the communities together and enroll patients. There's a lot of great ideas, and the future is very, very bright for this kind of thing. I think that the Lancet Commission and the Lancet giving an opportunity for world leaders to come together to set a blueprint of what could happen in the next decade, and then those people taking it very, very seriously, because there is no job that I don't take, that I don't put my entire effort and love into, then for the next decade working on it. Just in the first 3 or 4 years after the commission, we're seeing an entire change in the way clinical trials are being done, the way women leaders are leading clinical studies, and the information disseminating the information for women, and raising awareness. All of that is part of the top 10 recommendations that are kind of taking place almost in a viral moment. And I think I'm really, really proud of that. And we'll continue that fight because I think it's incredibly important. So thank you for that question, Mirvat.
Thank you so much, Roxana. And my last question, actually, you almost answered this, but I would like your opinion about. We asked the same question to Professor Brownwell, and I think it's very interesting. What would be the next 10 years in cardiology? Which field do you think will likely to take off? Like if you were a young trainee that you've done internal medicine and you are now selecting your cardiology and cardiology train, which field that you would focus the most?
Yeah, I mean, I think that people should, first of all, focus on fields that really, really they love, because I think that would be the worst thing to just see where, oh, I want to go to where everybody else is doing something. It sounds like a Instagram moment. We don't want that. We don't want people to just get an Instagram moment, because that's not real gratification in your heart. So your passion is really important. The thing that really speaks to you and makes you feel good about what you're doing is very, very important in terms of choosing. But what I think is happening is that we're going to, with all of the progress that's being made both on drugs and devices, I believe wholeheartedly that we will diagnose diseases much earlier. We will prevent disease earlier, hopefully, preventing the inevitable, first event, primary prevention, and then we will couple our interventions when it's needed, and our interventions will also be very precise, personalized, and extremely connected to how we could get. It's our opportunity to actually, since we have the patient there on a invasive intervention, to do our best so that when they leave, they're technically and mechanically revascularized or cared for, but then we couple that with prevention that is everlasting and durable. So I think it kind of comes before preventing that first event. In the unlikely event that the event happens, then doing our best in our intervention, and then coupling that with the best prevention. On these two sides, we've done terrible. We're not really getting patients at goal. We now have technology that is able to characterize patients and their plaque and the risk of the plaque in the best possible way, using AI and using really interesting multitudes of cardiometabolic risk that we now could attach to the plaque and to the patient. And then we hopefully can, avert this. But some of the modifiable risk factors are difficult to get to, like smoking, obesity, and obviously the kind diabetes. And those are modifiable, or cholesterol and hypertension. But we also have to think about some of these unmeasured confounders, or the kinds of things that we haven't paid attention to, like inflammation and very important stress, anxiety, environmental issues, and the kinds of things that we've never paid attention to in the cardiovascular field, like air pollution. And we need to kind of bring that all together, and then genotyping, phenotyping, and using the kinds of technologies that are available to us, and then the best incredible work that's being done on the pharmacologic prevention, but also lifestyle changes that could really, really improve and enhance where we're going. I think the future is just so exciting. I won't be here in the next century, but the next century will have a very, very fantastic, if we could save the earth, so that people who are now living longer could live on a planet that is there for them, then I think we're going to be in a very, very good place.
Well, Roxana, thank you very much for your time with us today. I certainly enjoyed it, and as I'm sure our viewers and listeners are going to enjoy it. And I can't imagine a better person to close off the series of diversity, inclusion, and equity with than you. You've been not only really a role model for women and young early career physicians, but you've actually been a guide, and you've opened opportunities for many. But you were also a driver, an impactful driver in the field of cardiovascular medicine. Your work in antiplatelets and antithrombotics, your work with stent technologies, and as you mentioned earlier today, the contrast nephropathy. I think these are going to be with us for a very, very long time, and with the field for a very, very long time. And so you really set a very high bar for everybody else who follows you. And Radcliffe Cardiology, thank you for doing this series. And Julia, thank you for being a friend and a partner in this series.
Thank you so much for having me. I really, really love this. It was so much fun to chat with you ladies. You were both true trailblazers, and you're achieving so much, and I look up to you too. So thank you again for having me, and I look forward to seeing you guys in person. And tell people to go to meetings in person. We all need the personal touch. It's difficult. It's time away from work and family, but make the time to go to the meetings and network and find friends. Find your work friends outside of your own work environment. Spread your wings. Stay strong, be resilient, work hard, and be happy most of all. Thank you.